And then we were involved. Okay. Welcome, everybody. My name is Susan. I'm going to be leading the meeting. Can we start with the people on the phone? I'd just like to ask you guys if you could type in the chat box your name and where you work, and then make sure that it's shared with everybody on the WebEx so that we can see who's here. And then obviously we have a new location this year. This is the room that we're going to be meeting in for those in the room. Go ahead and get started. We have Debbie, who's going to introduce our speaker. The talk today is When Booster Draw, Observations from a Novice Infection Preventionist.
Okay. Our speaker today is Trent McAllister, and he's an infection preventionist with St. Luke's Health System in Boise, Idaho. He has an MPH and an MS, and he works at St. Luke's, being involved in the surgical site infection prevention, water management programs, and oncology infection prevention. And this is the program that he shared at the APIC National Conference in Philadelphia last year. And a fun fact about Trent is the highest altitude that he's been is 18,514 feet. Where would that be?
That was in Nepal.
In Nepal. So anyway, we just appreciate Trent sharing this presentation with us, and there's a lot of novice out there, so maybe you can learn something from him. Thanks, Trent.
So yeah.
He hiked to Everest Base Camp.
Pretty cool. Yeah. So yeah, this is a talk I gave at APIC last year, and I was terrified when I gave it, and I have to say that even now, looking back, I'm like, okay, it was a good experience. I'm glad I did it, and I would encourage you guys all to think about it. It definitely pushed me outside of my comfort zone for sure, but it was a good experience, and it was good to kind of connect with other people and hear their experiences. And really, this was inspired just by, when you're onboarded as a new IP, you're kind of drinking from the fire hose. And so I kind of just wanted to talk about my examples and what I ran into. By no means is this right, wrong, the right way to do things, or anything like that. It's just kind of what my perspective is. So again, just wanted to share some examples of where infection prevention did collaborate, should have collaborated with other departments and staff, and then look at some of the policies, whether they might be unreasonably restrictive, and whether that's real or just imagined by the staff, and then just talking about strategies, how to dispute those kind of disagreements. So I did tweet during this. I don't have tweets right now, but that was kind of something that I did during that talk. So just how I ended up in infection prevention was really, an idea while I was at school. That's Dr. Pergam, who came and spoke at our 2018 annual conference. He's a huge advocate of infection prevention. He is part of the Seattle Cancer Care Alliance. He's the director of infection prevention there, and he just is super advocate for this. I did an internship with him when I was in school, and then I got got a job at St. Luke's. And so, again, this is kind of for people outside of St. Luke's. But this is how we are organized. So we're kind of broken into kind of a center of excellence, an ambulatory area, and then 3 different regions. And so it's been just a little over a year now that we've been in this structure. And so one thing I wanted to do, my background's in epidemiology, so I like numbers and statistics, and so I wanted to, kind of give you the characteristics of our team, what we look like. It's changed a little bit since then, I think. There might be, when did you get your CIC? Before June?
Yeah.
It was. So this is probably pretty similar to what we have now. Just to talk about what a win, a loss, and draws from, again, a novice IP. At the time that I gave this, I had been doing infection prevention at St. Luke's for about a year and a half, so long enough to get my feet under me and get through some experiences, but not really long enough to feel like I knew anything. So a win is just something that I had planned or I'd hoped for, or I was kind of imagining this is the right way to go. A loss is something that was kind of unexpected, didn't quite go the way I wanted it to go, and then a draw was something that I was like a little bit frustrated with at the beginning, but then maybe after some more work saw kind of, I think we maybe met eye to eye with whoever I was working with or department. So as a new IP, we all know we have tons of resources at our disposal. We've got, the APIC guides and the listserv. We've got national guidelines. We've got the CDC, especially the HIPAC guidelines. We've got journal subscriptions, conferences, networking. But what is really hard, I think, as a new IP is what does that mean in practice? What does that look like in your day-to-day life? And then, what about when you have conflicting guidelines out there, when AORN says one thing and CDC says something else? And then what about those gray areas that are not always addressed? I think we live in a very gray world in infection prevention. There's always areas that there's not great data for one way or the other, and then that always leads to problems when you run into people who are asking, show me the data where this shows this is what we should be doing, which can be challenging at times for certain recommendations that we're making. So one of the first examples or issues I had to work through with my colleagues was looking at surgical services attire, and at the time, the AORN guideline in 2014 changed from confining all, your ears, all hair, to just completely covering, let's see, what is it now? Cover all hair, but they don't say anything about the ears. And so there was some push at St. Luke's that, we aligned with we aligned with the 2014 AORN guidelines, which just say cover your ears and all your hair. And so we changed our policy to align with the AORN guidelines. And then a study came out, the Hats Off study, that said skull caps are not inferior to bouffants in reducing airborne particulates in the operating room. And so then a joint statement came out, and this was from the American College of Surgeons, AORN, ASA, APIC, and the Joint Commission, among others, that said it kind of punted. It didn't really make a recommendation one way or the other. And so then St. Luke's Surgical Services got on that and was very interested in getting skull caps back into the operating room. Also, this article down here by David Gorski is a pretty funny article. It's a kind of lighthearted look at the dispute between AORN and the American College of Surgeons. He is a surgeon, and he kind of takes a step back and tries to look at both sides with an objective view, and he makes fun of a little bit of both sides, which is kind of funny to have that commentary. And so we put together an SBAR, and actually this was from our surgical services department. They had sent this to us, and they were recommending that disposable and clothable caps are allowed back into the operating room, and that we are going to change our policy to say that not all hair needs to be recovered anymore, just that the scalp needs to be covered. And then they were going to say home laundered hats are not okay, which is currently our policy. And so they said, based on that consensus statement, we want to get skull caps back. And so they sent this to us and said, can you guys sign off on this for us? So after that,
Attention please. Starting at 2:15 p.m., the Hill ROM system will be rebooted. For any emergencies, please call 555. An announcement will be made when the system is operational. Again, starting at 2:15, the Hill ROM system will be rebooted. Please call 555 for any emergencies.
Okay, so they proposed a policy change, and they said, while we work through this, we'll enforce our existing policy, which is more or less only bouffant caps, covering the ears and all hair. So, infection prevention in partnership with accreditation, we did a literature review, we searched the guidelines, and then we kind of sent some emails out to accrediting agencies to see if they had any guidelines, what they would be surveying to and what that would look like. And so we also had our quality and patient safety leadership team involved as well, which was really essential to this group because they served kind of as the decision-making body, and they provided the consistent messaging for whatever was decided. And it was really critical to get them to buy into this process. Otherwise, it's kind of infection prevention versus the OR, and that doesn't always go so well. And so we, after that literature review, we didn't find anything really new besides that one study. The guidelines hadn't really changed, but we did get an email back from, I believe it was the Joint Commission, that said, whatever your policy is based off of, whether it's guidelines or literature, that's what we will survey to. And at the time, AORN hadn't changed their guidelines back to, they hadn't scaled those back yet. They had just been on that consensus statement that had scaled it back. And so with that logic, we said, well, AORN hasn't changed our guidelines, so we're not going to change our policy. And so that was a win. And it was really a win because we all got together, we collaborated, and we worked through this process together. And so while surgical services might not have liked that answer, they were a part of that decision-making process. And again, having that leadership team involved was really important for that buy-in. So we also did some other work beyond head coverings on surgical services attire. We had done a mock survey, and we had two findings related to attire. One of them was reusable endoscopy gowns, and one of them was croquis in the OR. And so what we found on the endoscopy gowns was that we had some reusable gowns that weren't being used according to the IFUs. And what it was is basically they can be laundered a certain amount of times and still be guaranteed as impermeable, as long as you check off how many times they're being laundered. But we weren't checking off, we weren't keeping track of how many times we were laundering them, so the permeability couldn't really be guaranteed. As for the croquis, we found some croquis in our operating room that weren't being cleaned, and they were found kind of dirty, had hair in them, things like that. They weren't a cleanable material, nothing to be wiped off. And so in both situations, we created an action plan, and we pulled a group together with kind of the department leaders, performance improvement, and infection prevention. And really, the performance improvement piece was really to formalize the process and kind of serve as a more or less neutral third party to facilitate the risk assessment process. So these are the tools we used for the risk assessment. And the departments were different, but the infection prevention team was the same. The PI person leading it was different, and then obviously the department leaders were different. So we came to very, very different conclusions on this, on these two risk assessments. So on the endo gown assessment, it was very low, so no intervention was necessary. And this is really like, these are the two biggest examples of differences that I could find. So really kind of like, oh, we don't need to worry about the endo risk assessment at all, and then we should be sounding the alarm bells for the croakies in the OR. And neither of those really sat well with me because we have kind of the extremes here, and in both situations it didn't quite feel like that. And so to me, this was kind of a draw. It wasn't something that I had originally, at first when I walked out of the endo gown assessment, I was really worked up and I was like, this is way too low, we should be doing something about this, we're not using these gowns appropriately. But really after more discussions with the department, they said, well, we're not using these for impermeable gowns, we're not, that's not what we're using them for, we don't need that impermeability guarantee. So working with them, that really helped. And then on the other side of things, we came up with a solution to get some cleanable croakies, which was pretty painless. And so really, in both instances, it was kind of maybe disproportionate, but really working with those departments kind of came to a shoulder shrug, if you will. So really, the lessons I got from this was just, national guidelines are important because they can help you when there's not clear data on things. It kind of standardizes your recommendations. The third-party resource, so in this case it was performance improvement, it is very useful if they can be impartial and kind of facilitate meetings. But you also have to kind of think about how you use that, because in those situations, a lot of that discrepancy was how impartial they were able to be. And so in one, we kind of had obviously very discrepant results. And then again, those tools, make sure that everyone fully understands them. We had a lot of issues with the definitions of what a occurrence is, what severity is, and what detection is. And so in both instances, I think we had multiple people thinking multiple different things about those definitions and what those meant. So make sure that everyone really understands the tools you'll be using. We also have a staph aureus screening protocol, so changing a little bit from attire to MDROs and screening. And so our protocol, it is for any patient with a history of MRSA, our adult critical care patients, and then high-risk surgical procedures. So we'll screen patients who are going to get, and for the most part, high-risk we classify as anyone getting hardware, basically, or an implant of some sort. So we do the testing in our pre-admission testing clinic. And then the screening informs our isolation precautions, whether or not we do decolonization, and then our preoperative antibiotic selection. And so this was an infection prevention developed algorithm. And so you can see it here. There's a lot of words on here, but really the takeaway is that it's pretty complex, and that we have 3 different patient populations on one algorithm. Which can kind of get confusing, and that's going to come into play when we talk about our staff. So we were getting a lot of pushback and questions from physicians and nurses. We'd hear things like, this is an undue burden to the patients because they're having to pay for this out of pocket costs. We would hear time constraints related to terminal cleaning of isolation rooms. And then, of course, I don't want to wear PPE, always a fun one. So we attended some staff meetings, and we really wanted to educate to our protocol, answer any questions that we could, and then maybe try and tinker our tool to make it more user-friendly. So we would hear things like, what's the history of MRSA? Is it 1 year? Is it 5 years? Is it 10 years? Is it forever? Does it matter how many negative screenings there are? What are patient pertinent risk factors? Because we had a call out for that, but we didn't really define what those risk factors are. We would have things like, what about out-of-town patients who aren't able to go to our pre-admission testing clinics? Why do we need to swab 2 sites? And then, the most important for staff is when can they come out of isolation? And so we took these and we brought them back to our infection prevention meetings, and we worked with the infectious disease physicians to come up with a solution to this. But we never brought any of the pre-admission testing staff or the surgical services staff to these meetings. We kind of worked through this based off of what we learned from staff meetings to try and develop our tool a little bit better to make more sense. But they were never involved in that process of developing or refining that tool. So what we came up with was an extended algorithm, and so what we did was we pulled it off where we separated our surgery patients from our inpatients and then also from our critical care patients. So we really kind of expanded our algorithm. And in addition to this, we provided a document of FAQs that is pretty lengthy as well to address all the questions that we were getting in staff meetings. But overall, we didn't change anything about our screening process or what we're doing or what we're asking. And so to me, that was a loss because we didn't really take into account any of the staff questions or any of the struggles or challenges that they were facing with that protocol. We just kind of put a new look on it, more or less. And so I think, to me, that was an area where we could have worked with them and made it a little bit more friendly, but we didn't really do that. And so, again, we still have confusion on this. We still get questions all the time. This is probably the one we get the most questions on. We still have some varied understanding and opinions within our own team. And then the literature on whether contact precautions are necessary for colonization is kind of mixed now. And it's our process for MRSA in particular is very inconsistent compared to our process for other multi-drug resistant organisms. We don't isolate for colonization for those, but we do for MRSA. And so really, it just creates a really muddy water for our staff to try and figure out. But one thing I really took away from this was just realizing the teaching role that we play as infection preventionists. We have a very unique knowledge base, and I think at the time of this, I definitely took advantage of what I know and how I understand these things, and realized that is not what our frontline staff understand. And so really being able to articulate the importance of these and how to make that stick for them. Another screening and isolation for multi-drug resistant organisms that I had worked on was with our BMT patient population. And so St. Luke's has the first hematopoietic cell transplant program in Idaho. The auto program started back in 1993, and the allogeneic program started in 2018. In 2018, there were 28 auto transplants done and 7 allo transplants done. And so what we did was our policies were kind of pulled from other institutions. We kind of leaned on other institutions' expertise in this because it's new for us, new transplant program for us. And so a lot of our policies were taken from major cancer centers, which is good, right? Like we get all of the cutting edge stuff that they're doing from those areas. But they also have very different patient populations than what we have, so that's something to keep in mind here. And so our oncology unit has both inpatient and outpatient facilities within the floor, so that also kind of adds to another layer of complexity when thinking about this. So we had monthly meetings established with infection prevention, infectious disease oncologists, and then the BMT nurses. And to really set up our program for this unique patient population, so we had a lot of things that we had to work through. One of the things that was implemented was weekly rectal screening for VRE. And so we would do this for every Monday, or I think it's every Monday, we would do rectal screening for VRE for PCR to determine colonization. And then the recommendation was do contact isolation for VRE positive patients. And if they're positive, they can be come off of isolation after 3 consecutive negative screens.
The Hill Realm reboot
or they can stop isolation when they're no longer an inpatient. And so this is one thing that I had worked on in school with Dr. Pergam at SCCA, was looking at our VRE numbers and what that looks like. So this was really interesting to me. I kind of had some background on this, and so I went back and I pulled our 2018 VRE isolates, and there was 32 total, and that was for 17 unique patients. So very, very low numbers. So that was a whole year of numbers, super low compared to some areas where they have 20 to 30%. And so did a literature review, and this was also partly easy because this was some of the research I had done in school, but pulling these, and one of the things that really started to pop out was a lot of centers were moving towards not isolating for VRE. And so these are, a lot of them are from pretty big institutions, but they looked at, they were doing VRE colonization isolation, and then they stopped doing that, and they just wanted to evaluate whether their rates went up, went down, and what a lot of these found was that there was no real change. And so based off of that, I kind of came back to the group and I recommended that we don't isolate for VRE positive patients. We had low numbers, we have single bed rooms, we have pretty good hand hygiene rates, especially on the oncology floor. And so that was kind of, and then this kind of literature review showed that we might not need to be doing this. And so that's what I brought back to the group, and then we had some discussions, and we decided that we would, in fact, isolate for VRE. That was a little frustrating at first, and so we marched on along, and which was weird, right? Like, here it is, the IP saying we don't have to do isolation, and the floor said, no, we're gonna do isolation. But then a few months went by, and a new discussion got started about, hey, well, are we supposed to be, do we have to isolate for VRE? I said, well, that's a great question. I think we can definitely revisit this, and we talked about it again, and they decided that because our numbers are so low, and the literature is mixed on utility of contact precautions for VRE positive colonized patients, that we would not actually end up isolating for VRE colonization. So that was one that I really saw as a draw. I was very frustrated at the time that you provide this recommendation and they go a different way only to come back around. But I think it was a good learning experience for everyone involved to just work on that trust and teamwork that it really takes to do our jobs. All right, and so my last example here is a pretty recent one, and this is also another frustrating one for me, but this is also in our heme and BMT population. So we, in the past, had gone about 20 months without CLABSIs on this unit. So then fiscal year 19 starts rolling around, and we start to see our numbers creeping up and up. And so we had requested a work group through our cross-functional governments to be stood up and address this, because this is not something that we had had historically, and then we are seeing an increase. And I think part of it was we had a BMT population, an allo BMT population now, so our patients are getting sicker. But really, we didn't want to look at that as that's an excuse for CLABSIs. We wanted that to be, well, we need to look at this closer. We need to be going, we need to be taking extra precautions because our patients are sicker. And so we pulled up a multidisciplinary group together, and we were tasked with identifying practice variation and noncompliance with best practice. And so really looking at, what are we doing currently and what should we be doing? And so this is kind of one of our bundle elements that's floating out there. It's never been kind of stamped with approval and sent out broadly, but generally, I think this is what our staff know they should be doing, or this is what should be happening, is our kind of central line bundle. And so we did some audits, and we found on our BMT population where we were compliant with our policy and best practice versus where we were not compliant. And so you can see where we had some areas of opportunity was ordering the ID protocol appropriately, which that will affect the number of flushes they get and when they get them. And then patients were not showering or bathing every 24 hours, and they weren't using their CHG wipes every 24 hours. And I can say I think that number of about 70% is pretty inflated. We just did some more recent reviews, and it's much, much lower than that. Those were kind of some of the top areas that we wanted to identify. In addition to this, we have heard some anecdotal instances of where patients' dressings and lines were getting wet after they were showering, and so we kind of wanted to look at that as well. So this is what the group had come up with. We put it on a kind of prioritization matrix to see, where are the interventions that we could be looking at that would have kind of a high impact and low effort, or high impact and high effort, those types of things. And so we worked through this, and what we determined was that we would do some dressing change education, and then we would do competencies. We don't do competencies for everything at St. Luke's. We have select ones that we do. And so dressing changes was not one of them. And so we decided that doing dressing change competencies for this unit would be good. We were going to provide staff tools to stress the importance of hand hygiene to patients and families. We had heard a lot that, nurses were helping patients from the bathroom, and they weren't stopping at the sink to shower or to wash their hands, and so really wanted to provide staff the tools to kind of intervene at that level. And then one new practice that we were going to do is have 4% CHG foam once daily. What we were doing was having the patients shower in the morning with soap, and then at night doing CHG, the 2% wipes. And so I think that was impacting our compliance a little bit, just because that sticky feeling, and really they start to not feel so great. They don't want to go up and shower, or they don't want to use the wipes. So we were having some compliance issues with that. And that was going to be an alternate to having the patient shower and then use the CHG wipes after their shower and have that kind of more 24-hour dwell time rather than 12 hours where we're having the CHG wipes and then 12 hours later having them showered all off. And then a couple other things, just dedicated mayo stands for dressing changes. What we found is they're setting up their sterile field kind of on the patient or whatever's around, so really trying to standardize that process and provide them tools to succeed. And then looking at the shower, the dressing after the patient has showered, and making sure that the lines are staying dry so we know that either what we're doing is working or if what we're doing we need to look at something else. And then really audit the CHGs and making sure that the dressings and lines are staying dry. And so again, doing a bunch of literature review to determine best practice on this. So this one I'll say is a win, and I put a little asterisk there because it's definitely been a win with some heartburn, but it's a win, we'll call it a win still. So it's ongoing. This is definitely one of the newest focuses that I've been involved in and continue to learn a lot as we go forward. And so as far as the novice observations go, some of the pushback with both these recommendations were delayed adoption of IP recommendations, and really looking at why that was needed or why that happened is probably effective communication, really being able to articulate where you're coming from, what evidence you're basing that off of, and why really we should be doing these things. And then, especially with the VRE situation, I think there was a lot of challenges with being confident in making our IP recommendation. There's so many times in this job where you think you have the answer, and then someone asks you just a different question, and you have no idea about that question that they just asked you. And so you go from being, confident, here's my recommendation, to, well, I don't know about that at all. So I think that that's one thing that the challenge for us, and especially newer IPs. But I think one thing that I definitely learned throughout this was the partnership with staff really helped with that decision making, being able to say, this is what I think, this is why, what do you think, is that doable? Are there other things that are not IP related that might impact that? So what do I know now after a year and a half? Or I guess now it's a little over 2 years of doing this. Again, going back to confident decision making and being able to know your resources, use your team, have your data prepared, and then find relevance to your site. Not all IP interventions are going to be relevant to your site, and so really taking what you can and applying it where you think it's needed. Think of the stakeholders and new IPs. So again, it makes sense to them, be open to alternatives. We all know that nurses and frontline staff can be very creative on things, so sometimes the creativity is just what you need. And then help with implementation anytime you can. And then probably most importantly is assess that intervention. Make sure it's not one of those set it and forget it type of things. And then lastly, just effective communication, really stating the recommendation, being open and transparent, and welcoming feedback and questions, and using many different communication platforms. Email alone is probably not going to be your best bet. You might have to do some staff meetings, education, PowerPoints. You might have to have one-on-ones, all sorts of different things to really get your point across. So there's the team from a while ago. It's still changed a little bit, but they've been awesome to work with and learn and grow with. And something that I've really valued is being a part of a big team. Something that, again, I said this in the journal club, but being able to share your experiences and learn from others is really important. And so I think that was probably one of the things that I learned the most after doing this presentation was going and talking to experienced IPs from around the country, and as I'm sitting up here talking about, I don't know if this was the right way to do this, but this is what I did, and you see the head bobs in the audience. It was kind of nice, and then people came up and said, hey, I've been there, this is what I did in this situation, I had no idea what to do here. So I think that was something that I learned from just giving this presentation. it's good to learn from other people. So, and I think that's all that I have for that. Any questions or comments or anything?
Can we do introductions before we kind of get into the questions and discussion? Let's start with on the phone. Can you guys introduce yourself, please?
Amy Bearlocker at St. Luke's.
Hi, Amy.
Lauren Wilson at Syringa Hospital.
Hi, I'm Jane Conkright from Riverview Center in Twin Falls.
My name's Chena McKechnie. I'm with Boundary Community Hospital.
Megan Prescott, St. Luke's.
Sarah Jones, St. Luke's.
Okay, well, welcome. Now, Tanya, you want to start doing introductions, please?
Tanya Siaka, 9P at St. Alphonsus.
That's very nice. St. Alphonsus IP as well. Boise.
Anita Partridge, First Choice Home Health. I'm not an IP. I'm an educator, an infection prevention educator, but I'm not certified. I'm Beth Ann Kavanaugh. I'm newly retired and newly moved to Boise, so I moved here from Providence St. Joseph System in Seattle.
Welcome.
Welcome.
Amy Russell, St. Luke's, Boise.
Nicole Nelson, St. Luke's, Boise. Samantha Birch, St. Al's, Boise.
Janet Brooks.
Where am I from?
West Valley of Caldwell.
Cindy Turney, St. Luke's.
Beth Sutton. I do IP and employee health at Valor Health in Emmett.
Jesse Bond, St. Luke's.
Susan Hepler, St. Al's, Napa.
Otto Swedan, Infection Prevention Center, Falls, Boise.
I'm Johanna Butler. I'm Infection Prevention and Education across the street at St. Al's Rehab Hospital.
Jordan Ashley, St. Luke's. Trey McAllister, St. Luke's.
Debbie Cutforth from Power County Hospital in American Falls, Idaho.
Sherry Colley of St. Luke's in Twin Falls.
All right, so with that, does anybody have any questions or comments for Trent?
Yeah.
What is a croaky? I've not heard that.
Yeah. So they're like I wear like retainers.
Oh,
Yeah.
A lot of times they're foam, like big foam, because they go under the edge of your glasses. So a lot of times I don't think people. A lot of times they're foam. So.
Would you go back to that slide with like observations and tell us what you actually were looking for? Because I had that question too. I was like, well, what did you mean by all of that?
Which one?
Keep going. Like the risk assessment? Yeah.
Oh, the risk assessment?
Yeah.
There's
Yeah,
all those.
like, yeah. Tell me like what you were looking for. Just I'm just how do you define them?
That is a very good question. And what I will tell you is still different than the person who told me how to interpret this tool.
I've never seen that before.
So,
Somebody
we
worked
about
at that tool where she came from.
The occurrence is the likelihood that the event you're thinking about is going to happen. So in this case, for the endo risk assessment, it was that your
gown would be
body fluid would go through the gown.
Okay.
To
and cause a problem.
Right.
Essentially. Okay.
The severity is what would be the severity of that problem if that happens. So basically, in this would be exposure to
body fluids.
body fluids on intact skin.
Right. Okay.
And then detection, and this is the one that I always get super confused on. I always thought it was just, are you gonna know if that happens?
Right.
But I think it's a little more complicated than that. And that's where I would say my answer would be different, because that's what I would say is, can you detect that the event happened?
I think it's essentially like, can you detect it and can you stop it from happening is essentially your ability to that. Oh, okay.
Yeah. So I don't know, these very, very much confuse me.
Yeah, okay.
And then what was RPN?
That's just kind of the number that you get, so you multiply all of those.
Right.
Here's how it stood for something. Yeah.
Risk prioritization. Risk prioritization, okay.
Oh,
that makes sense.
okay. I was trying to I knew it was the total of that, but I'm like, then what would that mean? And I couldn't figure out one.
Do
Do you guys have that you could email out? It'd be interesting just to.
This tool?
Yeah.
Mm-hmm.
I've just never seen it before either.
We have several different.
I was thinking at the time that I forgot about it.
And I think one thing with the Croce's risk assessment was everyone said that was like the highest number that they've ever seen on something.
Oh, that is big.
It was kind of funny because I didn't think that the risk was that high.
I mean, essentially, that's like an 800 would be like immediate death. Like death is imminent.
I know.
Because
And I guess
patient risk
also,
for harm, is it just because it's a dirty, like any other dirty surface that you're?
Well, so that's where this came in very weird. Is the first tool we had it with. Both times we did it with a different facilitator, and the first time they had a different definition of what. I can't remember if it's detection or occurrence were, and so we applied this very differently based off of that.
Yeah, you would, yeah.
So really, I think the occurrence for the second one, what we were looking at is we were talking about how the occurrence of the croquis being dirty, and so we said absolutely.
Because you can see it.
It's gonna be dirty. What's the severity is, something falls and causes an infection. And then the detection is, would you be able to detect if something fell into the sterile field and caused infection? But that doesn't line up with what the occurrence was if they're dirty, what happens. And so it was kind of, we took that and didn't apply it consistently for that one. And so that was where it was also just being able to use that tool, have your question that you have, really state that clear, and then apply those definitions.
So the occurrence would be like, what's the occurrence that's actually contributing to the infection? Yeah. And how,
So you kind of have to identify that before you apply the risk assessment so you're consistent on the answers more. So.
And really making sure everyone is on the same page with what those mean.
More definitions on each one maybe, and then so whenever whoever looks at it would be able to use it the same way.
Yeah, and you could, that's a good point.
And I think that was, the biggest thing is just we didn't use these consistently, and so we got very inconsistent results.
Yeah, I would say if you do use a risk assessment, that's what we're talking about, make sure you have like standardized definitions how you're going to apply those and that everyone at the table agrees.
Yeah, because it makes it look like absolutely, we're infecting every wound, so we are absolutely doing that. Some people just aren't getting sick.
So you've been working with surgical groups and looking at surgical side infections. It's multifactorial events. And that's why they implemented bundles, not certain limits. And the problem is when you talk to surgeons, they will show you, they will tell you which one worked, which one didn't work, show me evidence. That's a problem. How do you address that with surgeons if they did everything possible and they still have infection? And they ask you, what went wrong? What do you answer them?
Very good question. I don't know if I have a good answer in that case. I think
sometimes risk factors are different because patients. Obviously.
I was going to say it's their house.
Right. And they're still going to get an infection.
Because I was trying to wrap my head around the surgical side infection for colorectal. And especially the organ space, which happen. It's more dangerous than superficial. The problem is that if you don't have a leak or a source of infection inside, and the patient still develops some fluids inside, and these fluids get infected and cause a problem. I approached one of the surgeons and asked his opinion because one of the cases we couldn't find anything really. And he said there is a physiological portion to that the epidemiologists never take in consideration, which is the colon shed fluids to the peritoneal cavity and get absorbed. The normal human shed about 10 liters a day. So as we operate on the colon, we interfere with that process, so the shedding and absorption, because of inflammation, will be affected. So some people might collect fluids, and these fluids, if you have 10 microbes, might grow because it's a good place to grow and it can cause infection. That's why he believes no center can reach zero at all. And the epidemiologists, they just pull in stuff from there.
Same part of the body.
So I was like listening to him, and I don't know what to say to him because we really did everything possible in that case, and even the risk factor for that case was low, but we still have like some trouble with them. So.
Well, the risk was low, but it wasn't nil. So that's the thing. You're still going to have those. It just, yeah.
So I don't know how to like. I thought that some.
I don't have any people for
even if you're experienced, that's where you're like, I don't know. All you can do is follow best practice from what you do have.
Does anybody on the phone have any comments or questions?
Good job, Trent.
Thank you.
So I do want to say that we wanted, for the education committee, part of what we need to do is have evaluations on each topics that we present, and so you guys can have an opportunity to guide us on what you want to have. So I will have an evaluation posted on the APIC site, I think, because for the ones on the phone, it's hard to get your input, but maybe I could just have it scanned in and posted with his slides, and then you could go there and get it.
Do you have a link? Because I can put it in the chat box right now.
Right. I don't now, but I will get it.
Okay.
So that's what we'll do for the education ones is because we always pass it around the room, but when the ones on the phone, we don't always get your input, and we do want your input. So we'll just post an evaluation form. It will just tell you if you can tell us if it's been beneficial, the education topics, and then maybe what you would like to hear in the future.
Okay.
And with that, so our next meeting is February 22nd, and I do want to see if anybody wanted to do CIC questions. We don't have anybody assigned for that, and usually what we do is I think it's 3 to 5 questions, and we just put a PowerPoint up, and then you basically just facilitate that. There can be discussion on some of them. Sometimes there's not. But is anybody interested in doing that?
Yeah, I am interested to do that.
Well, I
You'll do that for
usually
February?
Kathy does it, but I didn't hear back from her.
Oh.
She's in the middle of a CMS survey.
Oh.
Okay, I thought New Year's, so I didn't know.
No,
But we could have more ones for
She usually
February.
has it on the computer and pulls them up, and she said unless there was a conflict, she would do that. And I had emailed her, but I didn't hear back, so I assumed she would do it today. But then when I got here, I assumed wrong.
Right. Yeah, no, we can our one can do it February, and then we can kind of go from there. So I think that's.
There's not much time. Usually it's about 10 minutes is what they allot, and it's on the website. It's on the Google Drive, the CIC questions. Aren't you on the Google Drive?
I cannot access it.
Oh.
St. Luke's has blocked every St. Luke's employee from Google Drive.
Oh, okay, I'm sorry.
Yeah.
Because I thought, well, we're on the Google Drive, we could just do that.
Are we talking about CIC study guide questions?
Yes.
I have the study guide in PDF.
Yeah, we have the book. Yeah.
Usually what we do is someone will pull together 3 or 5 questions and just throw them up here and then we talk about it as a group.
And then we'll just talk about it. If anybody's trying to study, it helps. So.
Oh, yeah.
Okay, so I guess with that, any final thoughts before we adjourn?
Any roundtable items?
Yeah.
Any burning questions?
Yeah, how are you guys doing with the coronavirus? Are you guys doing, I just had somebody, everybody's freaking out at my.
There's another update that there's
Another one in Chicago.
Yeah, there's like 22 they're looking at now or something.
about 61.
In Idaho, or in the U.S.?
In the U.S.
In the U.S., yeah.
Idaho.
No,
In the U.S.
That they're observing, but 2 cases.
Right, 2 confirmed.
Cases. 2 confirmed cases. And are they still saying that there's no patient-to-patient transfer?
No.
Okay, because I'm like, why aren't they updating this? This is like, okay.
There's very limited evidence on, they don't quite understand the transmission, but I think at this point, they've determined that there is some transmission occurring.
And they are asking for airborne, right?
The CDC is still recommending airborne and contact.
I thought it was funny, the picture of the airport scanning by the fever thing, because it has a 14-day incubation, right?
Well, 2 to 14 is what they.
Oh, I was gonna say, so I'm like, are they really gonna catch, like, if by scanning for fevers?
And when are they actually
Who's to say when they were exposed?
They haven't really seen any of that information that I've seen.
I have we have a few people that are going to Seattle for a conference, and they are totally freaked. They're like, I'm not getting on that airplane. Give me an N95. Give me something. I'm just like, you know what? You'll probably be able to sell them at the airport. So why don't you take a whole box?
Can I share something about airplane travel, because the airlines do not clean my daughter works for the FBI, and she travels a lot on planes, and she would get sick every time after she got off the plane after a trip, until she started, I don't know what wipes they have, but they're not Clorox. So they have some kind of antibacterial, antiviral wipes. She started taking those with her, and she said, like, if she sits in a 3-seat section or 2-seat, whatever, she wipes down everything. I kid you not. And she said she has not been sick since then. It's still the touch and keep your hands away from their teeth.
Let me tell you in a minute a funny story, a true story. It happened to me. I was flying from Vienna, Austria to Munich in 2017. I run to the bathroom very quickly. There was 3 gentlemen went out from the bathroom, didn't wash their hands. So, gross, I know.
This is in the airplane?
Airplane, yeah, in airport.
In airport.
Yeah, in the airport. So I rushed the airplane. The 3 gentlemen were in front of me in a queue boarding the same airplane. I felt gross. I have those things, I told them to stop doing things in airplane. Back then I have thick beard, so everybody was nervous, like a Middle Eastern with a beard fucked up. Like, I'm not kidding, not. Like, everybody looked at me. I'm pulling hand hygiene during, stuff.
Oh my God.
And I was like, Similar died. They beat him in Austria, by the way, when he was in asylum, and he got affected and died because of this. So I was thinking, they're gonna beat me to death like this. Similar. It was an hour and a half uncomfortable flight ever. After that, I stopped doing this. Let me die from infection. Get arrested.
Well, just share it around with everybody, because my daughter said when she does that, everybody around her thanks her.
Yeah.
Hello?
Hello?
Yes.
Hi, this is Christina Hart. I'm actually in Washington State, and I can review with you guys what Washington has sent out to us on the coronavirus. They want you to obtain a detailed travel history of anybody who's being evaluated of a fever and acute respiratory, and automatically suspect someone with this if it's within 14 days, or if they've had close contact with somebody. We are to put them in a negative pressure room immediately, and we are to be using airborne precautions with everything. They also want to collect a lower respiratory, upper respiratory, and serum specimens. Stool and urine may also be collected. And that's what our public health has put out for us.
Okay. So like just a nasal swab, or what kind of upper?
They want true sputums.
Okay, sputums and okay.
We'll say we're gonna be doing sputums, yeah. I hate sputums.
Okay, and then that's only CDC still, right? Yes. Testing? Yep.
Yeah.
Yes.
Sorry, Dr. Booth said that there was, Johns Hopkins had reported that there was some commercial tests that could potentially pick it up. But we checked with BioFire with one of the educators there, and so there's no cross-reactivity, so we shouldn't pick it up on that. So it's still unclear what it was, what platform was picking it up, but I don't know what you guys have, but it's not BioFire.
That's the only one there is, isn't there?
And they're going to BioFire apparently is going to put out an official letter next week.
Saying the coronavirus detecting is not the one.
Yeah, because that's the other question we're getting now. If people get coronavirus, then, you don't have that one.
All right, well, I think,
Traveled to SeaTac recently on Wednesday. To Seattle.
What was that, Megan?
You all know if my husband went to SeaTac in Seattle Wednesday.
oh, awesome.
So I'll let you all know if he, is the first time.
Yeah,
Did
Bob
you make
made
it
it
back?
back to Idaho?
Okay. That would be interesting, an IP's husband.
How exciting would that be? I could be like, oh.
You would make the news.
Wrap him up in some.
All right, so we are at time. So once again, I just want to say thanks to Trent. Just a couple reminders, this is our new location for 2020, for those of you in the room. If you are on the phone and you want to come, we do have the map inside the calendar invite, so make sure you study that before you head this way. And then finally, if you have any questions, our webpage is pretty informative. We have the agendas, we have the calendar out there. We'll add more as we, determine our educational meetings in the future, but you can reach out to any of us anytime, so thank you.
What about a sign-in sheet? Do you guys do a sign-in?
I'm writing your names down.
Yeah, you did a great job. Thank you.
Thanks, everybody.
Okay. Hey, Trent, you want to start the recording?
Yes.